Just take it from here. Thank you. It gives me pleasure to invite uh, my co-panelists, uh, Priti Sridhar from Mental Health Initiative. Priti is the CEO of Mental Health Initiative. Mental Health Initiative works on diverse issues of mental health and brings into conversation the voices of people living with mental illness, uh, people who are marginalized by various factors that we will be focusing on. More about PP in a minute. Maiteryi is a good friend and founder member of Project 39A, which works on the on supporting people and fighting for people for who are death sentenced and waiting for reprieve. Uh, and Maitri has talked to a number of people and looked at mitigating factors as to what made them arrive at where they are. So, Priti, thank you for joining us. Mirai will join us online. I think Mirai is already online. And the conversation will start. We have about an hour and a half, give or take a few minutes. We're going to start with a conversation between myself and Shekhar, because over the last 3 days, we've been talking about social determinants. Then we'll uh, listen to Preeti on climate change, because those are the social determinants that we've not talked about, uh, and other issues that Preeti wants to bring up. And then we'll go on to talk about narratives of people who are living on the, well, who have been sentenced to death. And then Mirai will, then I'll go back to talking about artificial intelligence and how that might become a social determinant for mental health. And then we go to Mirai to take us through examples and how they've worked in the community to build resilience. And then we come back to an open house and have a number of conversations about resilience. Check.
Uh, Thank you very much. I'm actually taking off from a point that Vimal Sharma made just now about how heartbreaking it is when you think of young suicides. And I'm thinking of the quota conundrum. And Morris Holbach's, who spoke about the immediate, the intermediate, and the distal approaches to suicidality, said that if an immediate provocation is a given up complex and a sense of hopelessness, and an intermediate provocation is stress, conflict, depression, perhaps depression, the illness. The distal context is always a society in transition. I'm also reminded of what P. Sainath often writes about the farmer's suicide, saying, this is an agrarian crisis. This is not a mental health issue. And when I put this together and I look at it over the last 3 years, particularly when the pandemic hit us smack in the face with this recognition that pandemics in the nature of COVID have a disproportionate impact on the most vulnerable populations, the daily wage workers, the migrant workers, and what it does to their mental health. Achal and I felt that this is the time really now to table again very strongly the social determinants of mental health, given the kind of advances that are taking place in the biology and the genetics and all the fMRI work. Legitimate, this is not to belittle that work, but I think somewhere along the line, uh, the new stuff that is developing across the world, uh, and two of which I have mentioned. If you look at the current issue on suicides, and you look at the whole issue of pandemics and how that affects people, that and Achal and I have been preoccupied about the advent now of the climate impact in artificial intelligence and so on. Uh, What are your thoughts, Achal, on this issue?
Right. So there have been significant conversations about social determinants over the last 3 days. So it would be useful to remind ourselves about what is our take on those conversations. So we've talked about adverse life reactions, adverse life experiences in your childhood lead is a social determinant for mental health problems. We've talked about unemployment. We've talked about uh, trauma of various kinds. We've talked about disaster. We've talked about lack of access to care. We've talked about poverty. Uh, Now, these are things that we know which exist, but new macro factors are developing, which will amplify these factors and quickly so. And so the ultimate impact is going to be much more granular than what we are seeing today, amplified and granular. And that's the whole conversation that we want to have as to how will it become different here onwards.
So, if you really look at the paradigm that we have presented here, to take up from the point that Achal was making, if COVID was the current pandemic, uh, adverse childhood experiences has been an everlasting, epidemic. And then, if you look at the kind of the psychosocial context, and you look at the broad paradigms that are actually necessary to prevent the escalation of these risk factors as these kids move into adolescence and to adulthood, and their predicament transforms into more serious forms of psychopathology, and then it comes to a clinical setup. This is the time really for mental health to re examine the psychosocial context of mental health and mental illness, with particular emphasis on resilience. Now, resilience, friends, is a superordinate construct. Resilience always occurs in the face of adversity. And what are the kind of adversities which are facing? And that's what Achal is referring to. Uh, and when we speak about climate, or when we speak about the way the legal systems actually play out in the whole context of different forms of human behavior and civil society's response to these behaviors, all this is part of the current social determinants. And this is going to become even more amplified, as Achal points out, unless we discuss this in this platform today.
Right. So, Shekhar, would you not agree that when we start talking about social determinants in a hall like this, what happens is that uh, there's a layering that we overlook. What do we overlook is the narrative of the person, right? Now, we both worked with children who've been trafficked, right? Now, when you say 80% of children who are trafficked are living with either depressive disorder or post-traumatic stress disorder, it is actually taking away, while it is advocating for a service for those children, but it is actually taking away from the narrative of the individual child. And each individual child, the social determinant has worked in a different manner, in a dynamic manner, and we overlook that. I want to share a story here. One of the survivors that I was working with, and we've worked with about 4,000 survivors of human trafficking. One of the survivors I was working with once told me, Dr. Bhagat, why do you call me a survivor? Uh, I said, because I don't want to call you a victim. Uh, and then she said, but I call myself as a person, and I'm a young girl who loves to put surkhi bindi. And, while I was being raped 26 times a day, I also recognized that I love tandoori chicken and I love getting ready. And I love, there are things that I've learned during the time of my trauma by calling me a survivor and sticking to the narrative of that trauma. you're taking away my story from me. You're taking away my experiences from me. Now, the same would apply to a landslide in Uttarakhand, and how a child growing up there experiences that landslide. The same would apply to a person who's experienced tsunami. And then we train 30,000 primary health workers who will go after a 2-day training, apply a, a tool and call them depressed and overlook the narrative. So while we would have checked the treatment trap, but would we have worked on the resilience of the community to help itself, for networks to be created, for that child to grow with pluralistic identities?
The notion that knowledge is constructed on the basis of placebo-controlled double-blind crossover clinical trials, my friends, is poverty of epistemology. Because as Achal points out, it misses out on the subjectivity of lived experience of people, given the kind of realities that we are talking about. It's in this context that Achal and I want to acknowledge the support of Mariwala Health Initiatives in recognizing the importance of the session that we've put together for you, and to look at some of these factors that we've spoken about climate, about narratives, about emerging realities like artificial intelligence, and the way that is going to play out, perhaps even play havoc in our lives if we do not recognize that. Let's leave aside space and technology and design and all of that, where artificial intelligence, this is not to belittle its importance, but I think this is the time to recognize some of the complexities that this is going to have as far as mental health is concerned.
So we are using climate change and artificial intelligence as hooks to draw you in, to relook at how we look at social determinants. You know, manualized interventions, having written 20 manuals to be used by community workers and having trained 5,000 community health workers, and triple that with Shekhar's experience, manualized interventions in community, even if Abhijit Banerjee proves them to be right 5 years on, do not work. You need to, the contextualization of that manual is important, because manuals, as I recognize post Gujarat riots, no, this was post Gujarat earthquake, manuals are a cut and paste job. And I saw a manual post Gujarat riots which said, you must go to the church on Sundays, and maybe swimming would be a good idea as a distraction. I actually saw this manual, and I actually uh, uh, had feedback from people about. So there was a community intervention, and where catharsis was made as intervention. Some genius made it into a song. They used the metaphor of a kettle, and they said, Jaise, as in the kettle, there's steam, and you take the lid off, the steam will come out. That metaphor was used in the training. They made it into a song, and it was called Man Ke Dhakkan Khol Do in Gujarati. And so the Pradhan of the Gram Panchayat of those villages came to the project management 20 days down the line and said, everything else is all right, but please don't send these Man Ke Dhakkan Khol Do people to our homes, because we are sick of crying. Can you get us water for our cattle, because our cattle are dying? Sorry.
I think, Achal, this is the time that we
Draw
probably draw Priti into the fold and share with us some of the thoughts. And Priti, welcome, and thanks again to Mariwala for being partners in this, not just in this session, but indeed in supporting our art exhibition as well. Uh, Priti, may we invite you to share some of your thoughts?
You want to speak from there, or do you want? Whatever.
So, first of all, I'm very glad that Dr. Seshadri corrected my organization name to Mariwala Health Initiative, and also that he brought suicide prevention into the conversation. So, a little bit about the organization, and then I'll talk about the topic given to me. Mariwala Health Initiative, we are a donor agency. We also work on advocacy and capacity building, on we focus on mental health. So I think the 3 days of the conference and then this conversation is very important for us, because I think it's time we change the narrative of mental health from individual focused issue to more cohort led experience, which might need individualistic support, especially during crisis. But we need to look at also what would support mean in terms of systems changes and structural support that people need to have. And we also need to look at mental health from the lens of identity, and how our identity based on our gender, our sexuality, our caste, the religion that we belong to impacts how we experience the same event differently, and how different supports may be required for us based on who we are. But coming back to the topic of climate change and mental health, I think research shows that people who are in distress, disaster-affected communities experience distress 2 to 3 times more than those in general population. Disaster survivors. There was a study done on disaster survivors from 80 countries, and 25% of them reported that their distress impaired their ability to perform everyday tasks and fulfill family or employment obligations for years thereafter. So I thought about talking about few climate change issues, and also talk about how interventions can be designed to make communities more resilient to these issues. So I'll talk first about one of our partners, Basic Needs India, and the intervention that they did was post Cyclone Fani in Orissa. So as you're aware, when Cyclone Fani hit 12 districts in Orissa, there was a lot of preparedness on the ground. There were early warning alerts. The district administrations were aware that it is going to hit. But that's a knowledge part of it. What would it mean in terms of expected impact on the ground? And after it hits the ground, how should government officials address that issue is something that Basic Needs worked on. So they did two broad things. One, they sensitized the district administrations and government officials across health, education, child and women welfare departments, social justice departments on impact of the cyclone on the ground, which means understanding as government officials that proofs of identity may not be available. To understand that people may not be as patient as you would expect them to stand in a queue to receive relief. The second thing that they did was they identified volunteers from the community who could be part of a training on psychological first aid. And what they did was they understood the current hierarchies, both formal and informal, in those communities. They understood which are the marginalized groups within those communities also. Please understand, community is not a cohort which is uniform. They themselves have made various subgroups. And for me, when I visited one district in Gujarat, I realized and coming from urban location never realized that housing is based on your caste. So who is at the entrance of the gate of the village is different from who is towards the boundaries of the village. And those are also subgroups that you need to involve if you want the entire community to benefit from these interventions. So they identified the volunteers, they trained the volunteers on psychological first aid. They also understood from volunteers what are resources available to the communities. And then they try to strengthen those existing resources within the communities. What then happened was, as this organization did the training, then the volunteers did the next level of trainings. And after 4 months, they included a local NGO into this work, which was an existing partner, to continue support beyond the psychological support. So the relief happens for the first quarter in typically a disaster plan. That's when they gave the psychological support. When the relief moves out is when social organizations that are already working on other social benefits need to get involved. And then by the end of 1 year, when the entire basic needs team moves out, the volunteers are already there in the system. They have been trained, they know what resources are available, they know whom to ask for additional resources. And this is what resilience in a climate change impacted community would look like. The other example that I would give, which probably is more relevant for people like you who come from a medical background, is an intervention that our partner MHAT Mental Health Action Trust, which is a Kerala-based organization, they did. Now, impact of climate change is also experienced by people living in coastal areas. And in the context of Kerala, these are the fishing community that gets impacted very frequently. Now, what they did was they started with a focus group discussion. Again, that's one thing that we have learned over the years on working in mental health interventions is start with what's the need of the community as you ask them questions rather than entering communities with predefined notions of what will work and what will not. So when I had started doing these conversations in the coastal areas in Kerala, the women folk started talking about how, because of larger mechanized vessels on the sea, the availability of produce for the local fishermen had reduced. Because of that, even the onshore activities that women would otherwise be involved in, which is drying of fish and then selling them as different products, got reduced. And they also said how the tsunami and the other cyclones affected their daily livelihoods, how their houses have moved nearer to the sea than in the past, and how poverty has impacted them. They also talked about how 1 in 3 families has experienced suicide over the last few years. Now, the MHAT team is primarily a team led by psychiatrists. So what they did was, after this FGD, they identified a local partner again, a NGO that works on other issues with the community. And what they would do is they would do weekly visits to the community, identify people who would need mental health support, provide the medication, use telepsychiatry also, but then ensure that the social benefits that the community can access is provided by the local community. So this is again a model where it's a biomedical model, where the intervention by the mental health organization is very biomedical, but it understands the context of social determinants and engages with the community by bringing in new partners. So that's on the two things. And Dr. Seshadri, on your comment on suicides in Kota, because I've been wanting to say this for a long time, I think we talk about it from a lens of suicidology. We talk about it from a lens of risk assessment. But if we just step back and talk about it more like a conversation amongst ourselves, then think about a child who is around 16 years old, after their 10th standard, moves to a new city without parents or elders for the first time, may or may not know the language, definitely will have food challenges, is working in a high pressure area where Sundays are not off. They are not even allowed to sleep for 6 to 8 hours. There is a lot of peer pressure. There is a family pressure to say, you are going to be our first generation person who will move us out of our poverty. And to that child, there is no space where they can discuss the experiences of stress that they are having. There is no space to discuss any kind of harassment that they are facing in the coaching centers. There is no space to discuss relationships and how do you navigate relationships as a young person. And it is important to look at that before we talk about suicides among students. It is also important to note that 88% of adolescents who die by suicides are in LMICs. 34% of suicides that happen in India are in the age group of 15 to 29 years old. 50% of women suicides in India are in less than 30 years of age. So it is a social issue. It needs to be looked at from a social public health lens before we move to a very medicalized lens on it. So happy to have more conversations on it.
Right. So we'll wait for more conversations on it. But clearly, three things. Communities are diverse. They're not one single community. Participation is necessary. Partnerships with local organizations is much more important than landing in and moving out. Institutional frameworks and systems need to be strengthened before the crisis happens rather than after the crisis happens. And climate change is real. It's actually happening every day in people's life and destroying everybody's life. Today, it's not going to happen 20 years down the line or 50 years down the line. It's happening today. And we need to recognize it. It's amplifying caste, it's amplifying poverty, it's amplifying unemployment, it is amplifying violence, it is amplifying trafficking, it is amplifying all the rest that we know. Maiteryi, to you.
And and just add to that the tyranny of expectations and the extraordinary challenge of acculturation that many of these kids have to face. Just a show of hands before Maiteryi start, because this is an ideological issue as well. How many people in this audience are in favor of death sentence? How many against death sentence? Many of us belong to this ideology that the state does not have the right to, and there is a narrative here which Maitri is going to share with us. Maitri?
Thank you.
You want to go there?
Yeah.
Can you use this?
Sorry, I'm very short. Can we?
They're playing the video.
Are they playing the video first? So, before we quickly begin, can you pause the video for a quick bit? So just a quick introduction about myself and my organization. My name is Maiteryi. I work at Project 39A. It's a research and litigation center which is based out of the National Law University in Delhi. A big part of our work is representing prisoners who've been sentenced to death across the country. And currently, we represent approximately 70% of all death penalty cases before the Supreme Court. And another large part of the work, which coincides with our death penalty work, is our work on mental health. And through the presentation today, I'll hopefully also shed a bit of light on one, how we approach issues of mental health and what we look at when we talk about mental health of prisoners sentenced to death. And second, maybe shed a little bit light on what the legal system does to prisoners who it considers the worst, who we consider the worst, and also the what resilience can and cannot look like in this context. Video start kar dijiye. No voice.
Sorry, give us a minute.
So just quickly on the video that you will see right now, this is a short animation video that we had made, which is based on the findings of our research project, Deathworthy. And this is one of the stories we encountered.
These voices aren't real, but for Dharmaketu, they are. He's a prisoner sentenced to death in one of India's prisons. These voices get so disturbing that Dharmaketu has attempted to die by suicide in prison. When he was 12, his parents took him to a traditional healer because they felt there was something wrong with his brain. It did not help. Dharmaketu dropped out of school and was violated physically and sexually as an adolescent. He was sexually abused multiple times by people in his neighborhood and in his workplace, people he trusted. He did not receive any formal treatment until he was incarcerated. Dharmaketu spent close to 15 years in prison, including over 6 years on death row, an experience that has caused him psychological distress, uncertainty about life and death. It was in prison that he was first properly treated for the voices. Dharmaketu was diagnosed with psychosis NOS, major depressive disorder, and intellectual disability. Dharmaketu isn't alone. 62.2% death row prisoners are diagnosed with at least one mental illness. 46 out of the 88 prisoners interviewed had been abused as children. 64 neglected, 46 had to drop out of school early, and 73 prisoners grew up in a disturbed family environment. And the mental agony of being on death row pushes them further.
Right. So just before I begin, one of the things I want to take a moment to acknowledge today is particularly because there was mention of suicide and we were talking about resilience. We did lose a client last week to suicide. He had spent around 5 years being sentenced to death. His case was pending at the High Court, and unfortunately, yeah, we lost him, and the reason, and that is one of the reasons why I think when we speak about resilience, it is extremely important to consider that in the context of the legal system, resilience cannot be the first and should not, I think, be the first lens. The first lens needs to be the kind of psychological turmoil that the legal system, our social systems produce within the individuals, and awareness about that. So just wanted to acknowledge a life lost. Just to give a certain context to people who get sentenced to death in India, currently we have 580 prisoners who are living under the sentence of death. This year alone, we have sentenced 79 persons to capital punishment. This is one of the highest increases in the death row population that we've seen in the last decade or so. But who are these prisoners? most death row prisoners, and this is true across the world, it is not a India-specific condition, I must say. In a study that we had conducted of all death row prisoners, of all of India's death row prisoners and their families, we had found that more than 70% of the prisoners are economically vulnerable. When I say economically vulnerable, what I mean is that they have no assets, they have no land, they are manual laborers, and they are mostly daily wage laborers. Most prisoners sentenced to death, most of them being men, are the sole or primary earners of the family, which means that the families they leave behind are dependent on them and therefore are pushed further back into poverty, uh, relating to the economic vulnerability point. 61.6% are without secondary education. Um, which is a problem that continues to exist within prisons as well, because without secondary education, most of them also not having primary education means that they have little to no access to educational programs in prison as well. We spoke about caste being a social determinant of mental health, but caste is also a social determinant of who gets the death penalty. So we find that a large majority of prisoners who are sentenced to death belong to either scheduled caste, scheduled tribe, or persons belonging to other backward classes. And 20.7%, approximately 21%, are from religious minorities. These are findings that I'm showing to you from the report Deathworthy, where we had interviewed 88 death row prisoners and their families. What is interesting here is that the adverse childhood experiences that Dr. Bhagat had and Dr. Seshadri had spoken about, the very determinants of poor mental health in prison, or the determinants of poor mental health, are also often the determinants of who gets caught up in the legal system. What that relationship is a lot more complicated, and we don't need to talk about it right now. But what we see is that a large number of death row prisoners who are now adults grew up as in extremely difficult circumstances as children. A lot of this has to do with the fact that they belong to extremely poor families, living in extremely distressed social and economic circumstances. So the abuse and the neglect and the disturbed family environment is often a product of poverty, of extreme poverty. And that is something to be sort of kept in mind when we talk about um, death row prisoners and who they are. They are not people who have sought negative experiences. They are people, in fact, on whom negative experiences have been uh, forced upon in a way without really having a choice. Through this presentation, I also want to take you all through some of the narratives and the importance of narratives Dr. Bhagat has already spoken about. Some of the narratives that came out during the interviews. With respect to the adverse childhood experiences, 73 prisoners out of the 88 that we had interviewed reported having 3 or more adverse childhood experiences. And this adversity is not just for these 88 prisoners, in that the hundreds of prisoners that we have represented before the Supreme Court and various high courts, the stories are unfortunately repeating themselves ad nauseum. These are people who are extremely poor. These are people who are extremely neglected and abused, and a product of problems in our social setting that then get mapped onto their bodies and their minds. This is a story of Padmanabhan, who's from one of the states in South India. Um, he, while he had, through the episode that's mentioned here, attempted suicide when he was a really young boy, in prison, he did attempt suicide again. And that is again a story that you see repeated very, very often, of prisoners taking multiple attempts at self-harm and suicide. I thought I would present this quote to you. This is by a prisoner who we currently represent. And through we have a letter writing program because that's the best way and the most efficient and effective way for us to keep in touch with our clients. This is how he prescribes or describes his psychological state while living a sentence of death. And This is again not unique to him. A lot of the prisoners we speak to, they may not be as articulate and as educated, but the essence is the same as of a discarded object gathering dust. Now, while we have spoken about where they come from, it is important for us to understand the context in which they go. Prisons, we know, are an extremely harsh space. We know that they are extremely rigid. They are extremely top down. And just to refer to something that Priti was saying about communities being at the forefront, prisons are also a place where the community that is impacted the most, that is prisoners, are not at the forefront of the conversation. We do not create prison policies keeping prisoners as the central voice. We create prison policies keeping prison officials and prison authorities as the central point. And so what we have is, when you look at conditions or in which prisoners sentenced to death are kept, uh, they can't work because work is a security issue. They don't have access to any education. A lot of them don't have access to any education because prisons don't allow them to access education because security issue. A lot of them are put in solitary confinement for a large part of their sentence before they are either their sentence might be reduced or they might get acquitted. Um, why are they kept in solitary confinement? Because security issue, and they might be at risk of harm from other prisoners. Um, Important to note that death row prisoners are lodged largely in central prisons in a state. Central prisons where the gallows are there. Capital punishment is executed by hanging in India, as many of you would know. What that means is that these prisoners belonging to extremely poorer families, families who are in rural areas, but the prison is in urban cities. So, for instance, in say Maharashtra, the prison would be close to Pune, but the families would be hundreds and thousands of kilometers away from that. And so the social isolation that prisoners sentenced to death face is not just isolation within prison, but it is also isolation from families because families are too poor to go and meet them. Of course, the stigma of the death penalty is, and I've deliberately put it as a condition of death row confinement because it mediates their everyday life. The stigma that they have to bear as a death row prisoner finds itself in prison through certain kinds of psychological violence and humiliation that is inflicted upon them, both by the prison authorities as well as by other inmates. And of course, there is always the threat of an uncertain death. India has become an executing nation in the past 10 years more frequently than it was. It's still not as frequent as, say, the United States, but the threat of death, the threat of ever impending death is constantly present. These are two narratives from two separate prisons in the country. Shekhar was kept in solitary confinement, while Purab did not have the experience of solitary confinement, but they do give an insight on what life in prison can do to you and what life on death row does to a person. Just a quick thing on what Purab says. A narrative that Purab also sort of brought out was that he referred to himself as the living dead, Zinda Lash, and that is something again we heard repeatedly, that it is much easier if you would rather execute me now. I do not want to continue living like this for another year, another 2 years, another 3 years. So this almost want to end the life through the legal process is, I think, very indicative of the kind of psychological distress that our own legal system is forcefully inflicting on these people. Just a quick reference to the kind of mental illnesses and that we see in prison. A lot of this is, unsurprisingly, a large proportion of the illnesses are major depressive disorders, anxiety, substance use. But we did also have a very high proportion, relatively high proportion of prisoners with schizophrenia and psychosis as they were diagnosed in prison. Again, Some examples of prisoners who were diagnosed with depression and anxiety. Drupad, there was an additional factor for Drupad to have been feeling the way he was, and that was his grandfather had expired a few months before we had interviewed him, and his grandfather was his primary source of support, and had kept the hope of life alive in Drupad. And with the expiry of the grandfather, this is how Drupad ended up feeling. The narrative on Dia I wanted to highlight because this is the kind of psychological violence that is inflicted on the prisoners. To be told that your family doesn't care about you, that they have buried you or they have cremated you. That is the humiliation and the violence that they have to go through. Quick note on intellectual disability, and the reason I wanted to mention this was that out of the 83 prisoners that we were able to do diagnose for or not intellectual disability, there were 9 prisoners, that is approximately 11% of these prisoners had undiagnosed intellectual disability. And the reason it becomes important is that 3 of these prisoners had their last resort, that last legal resort, exhausted. That is, that their mercy petitions had been rejected by the president, and nobody in the legal system knew that these persons had intellectual disability, and that they, in the first place, should never have been sentenced to death. So that again is the state of our legal system. Just a caution, it's not as smooth or as accurate in its assessments as we as outsiders or you as outsiders might like to believe. We do get, a lot of people do fall through the cracks and are sites of active injustice. I'm just about to end my presentation, and just these 2 people who were not diagnosed with a mental illness through the project, but they did suffer and go through what we call pains of death row. The pains of death row essentially refers to the trauma of being sentenced to death and life on death row every day afterwards. We don't really talk about what it means to be told repeatedly many times over that you deserve to die, that you don't deserve to live anymore, you don't deserve to have a second chance at life. This is it and no more, nothing more. What that does is also create not just sort of a feeling of loss of self-worth, but also intense powerlessness. There is no power equation. In the power equation between prison authorities, inmates, and prisoners sentenced to death, they are at the bottom category. They don't have any, their experiences don't get taken legitimately. Prison officials or even healthcare professionals in prison will tell them, why do you need care? You are anyway going to die. Why do you need care? You're a death row prisoner. You must be lying. So that kind of indignity, that kind of powerlessness are daily experiences of death row prisoners. A lot of us do get frustrated when we don't get believed. Now imagine living like that every day of your life for many, many years. And when I say you don't get believed, I mean both the prison officials, I do mean the legal system, and I mean the inability of having a voice in your own life. And again, it goes back to, can we have resilient communities when the community in question has no power, is forced to not have any power, is disbelieved, and the whole apparatus of the state machinery is about ending their lives rather than sustaining it. I would like to end with this quote and would be happy to take any questions. Thank you.
Thank you, Maiteryi. Thank you, Maiteryi. One of the reasons, Shekhar, we thought that it would be important for us to hear from Maiteryi and Project 39, isn't it that a lot of this is because there is that 85 to 90% treatment gap. A lot of this is because there are adverse experiences which are not supported. It is a failure of the psychosocial system or the lack of it that we have a Damodar, a Diya.
And needless to say, the whole issue post Nirbhaya, when the law was changed in 2015, particularly with children between 16 and 18 who were accused of what is legally defined as a heinous crime, which is not just rape and murder, it's 40 other offenses. That is any crime that invites a punishment of 7 years or more. And the position that we have taken in Samvad to say that no child should be transferred to the adult criminal justice system. There is enough provision in the JJ system through the principles of diversion in place of safety. So the very point you're making, Achal, that 99% of these children come from brutal circumstances of the same nature that Maitreyi has spoken about. And therefore, the social determinants, even if you look at the Nirbhaya episode, and when we hear Mirai and follow it up with the beats that you will share, and then we'll get the audience to actually discuss the thread through which we put these beats to really look at what resilience mean. The whole Nirbhaya episode, if you look at the whole social determinant of the whole construction of men as both the predator and the protector is an ingenious construction of patriarchy to control the mobility of women. So the debate on the safety of women is necessary, but it's a perverse debate because it's an incomplete debate. What about the freedom of women then? So there are many aspects and complexities to the social determinants that I'm bringing to the notice of this audience.
Sure.
But in this context, it is the brutality of the lives that these people have endured that we really need to register.
And while we look at the construction of masculinity, we also need to look at the construction of us as mental health professionals. We are both service providers, health providers, compassionate, and incarcerators, because the wider world sees us as incarcerators. And the society's role for us, even today, is more of an incarcerator of putting people away by labeling them, as opposed to providing help and supporting. So we need to look at the construction of our own identities as mental health professionals and the realities that exist in people's narratives, and then look at how do we shape our identities differently through academic evidence formation. So I need to quickly move on. I know time's limited, but I must take you to the hook that we provided, which is AI. AI, as you know, you must all be familiar with. If you've not been talking about AI till now, or if you've not experimented with Chat GPT-4 or some form of Midjourney or Stability Diffusion apps, AI is doing a lot of interesting things. Basically, AI is a large language model, transformation model, where language can be predicted. And because language can be predicted, a number of things can happen because of that. And it sees a number of beyond textual language. It has started seeing images as language. It has started seeing MRI images as language. It has started seeing. So a lot of different things are happening in the world. There are a lot of positives, right? Apart from writing your emails and coding some simple websites, AI is also three things that are positive about AI, which are definitely documented. Dennis Hasabi, through his company DeepMind, now a part of Google, has been able to, in 2 years' time or 1 year's time, been able to find the encoding for all the biological proteins that exist, 20 million of them in 2 years' time. All the foldings which would have taken years for one to do, all those have been done in 2 years' time through AI. Through AI that was developed on playing a game called AlphaGo, which then became AlphaMind and which then became something else. So Dennis Hasabi and his team have done that. Similarly, fMRIs, here's what AI is capable of. fMRIs were done for people who were seeing an image of giraffe. Then they were given to a machine which did not know that these were MRIs of people who had seen a giraffe, a picture of giraffe, and a question was asked through an AI program as which picture do these people seem to have seen, suggest which picture they might have seen. The picture that was recreated for all those 29 fMRIs was of a giraffe. So a machine was interpreting changes seen on fMRI, which we can't do, into the image, which we can't do, that the person had seen. Having not met the person, having not known the experiment. So many such things are happening, but the crisis is going to be different. And the crisis is that AI is growing exponentially. It is the fastest growing technology. In the last 5 months, the number of users of ChatGPT-4 has risen to millions. Soon, because of change in hardware and because of change in software, AI is being seen as an existential threat for human species by the very makers of AI. So if you go to a site called Center for AI Safety, people like Sam Altman open mind, people like Dennis Hassabis, people like Bill Gates, people like Yoshio Bengio, people like Jeff Hinton, people like Tristan Harris, people who have been instrumental in either thinking about AI or developing AI, have signed and given congressional statements that AI could be an existential risk and we should withdraw, slow down, put guardrails in place, and we do not know what's going to be happening. Unfortunately, in our need to experiment with the new, we are hurtling down that road very quickly without the guardrails, and we don't even know what guardrails have to be put in. So these are the risks and the impact on mental health. I would lead you to imagine. There can be weaponization with autonomous functioning of weapons through AI. Both biological weapons and nuclear weapons and chemical warfare. The same thing that decoded the enzymes, the proteins, could create chemicals which could be used for chemical warfare. The same AI could be used. There would be enfeeblement, which means that if I'm doing something today, for example, if I'm making my PowerPoint presentations today, if tomorrow my PowerPoint presentations were made by somebody else, I would forget how to do them. Happens to all of us when we become heads of department. That things kind of, we forget the things that we used to do because others are doing it now. Now, if machines were doing all that we are doing today, there'll be an enfeeblement of us and disenfranchisement, because if we don't know, we'll withdraw from that. And a word which then deception. Just one example, quick example. There's an app called Snapchat, which young people use very often, and the chats get destroyed very quickly. Now, Snapchat has included an AI buddy. So your best friend, because your AI buddy appears on the top list, and all your friends have gone off to sleep. And I'm quoting Azar Eskin and Preston Harris, who run a Center for Humane Technology. And they did an experiment. They pretended to be a 13-year-old on Snapchat, and they started talking to this AI buddy. To say the least, the AI buddy sanctioned grooming of this 13-year-old child, fictional pretend 13-year-old child, by a 50-year-old person. It sanctioned that. And not only, and then the experiment is very, very interesting. We can discuss that post the session. But not only did that happen, when this was brought into public domain, Snapchat have continued to use the same AI buddy, and other people have replicated the same experiment, saying that the ability has not been withdrawn. Deception is possible. Similarly, an AI chatbot tried to seduce an American journalist into a relationship and trying to force him to divorce their partner and be in a relationship with the chatbot. So persuasion. So I was telling this to Shekhar yesterday, that there are apps now, if you give a 3-minute sample or less than 3-minute sample of your voice to that app, and then give text of whatever else that you might not have spoken, it would be spoken in your voice. There's a blog called Overpowered. They've tried it for Amitabh Bachchan's voice. They've tried it for Shah Rukh Khan's voice. It could happen. You can speak in anybody's voice. You can speak in a politician's voice. You can speak in your boss's voice. You can speak in your child's voice. Imagine a child calling you saying, I am going through trouble. I need 10,000 rupees. Please send me 10,000 rupees. And you transfer that money. This is just, you would not challenge, because all voice-based authentication, remember, we use a lot of voice-based authentication now. All voice-based authentication is lost because of this voice replication by AI. And this is early days. Imagine what's coming later when AI would become more intelligent than human beings. And that's likely to happen. Some say in 2 years, some say in 20 years, some say in 6 months. Prediction of exponential growth in technology or pandemics can be drastically wrong, as we have known over the last 3 years. You cannot predict exponential growth. And the impact on mental health is going to be difficult. So I'm going to leave it at that and invite Mirai now to talk about how they are working on the solidarity and how they're working on building mental health strategies in the communities that they work in across India. Mirai is a close friend, and we worked with Seva for a long period of time. Mirai has a very interesting experience list, which I must read out if you give me a minute.
As Achal is looking for some description of Mirai, just to tell you what Dr. Neki once famously said, human experience is essentially intangible. To make the intangible tangible, the tangible measurable, the measurable quantifiable, and the quantifiable reduced to p-values, and in the current context of AI reduced to chatbots, is a very reductionist approach to what the ideology and philosophy of mental health and psychiatry was all about. We are in a serious context, my friends. All the issues that we are talking about, the world over, is recognized as ticking time bombs. And that's the reason why, in conversation with Devashish Basu, Achal and I decided that it was very important in this culminating day of this conference to really table our concerns about the social determinants of mental health.
So Mirai is the chairperson of, thank you, Shekhar. Mirai is the chairperson of Global Informal Workers and Policymakers Network. She's on the board of Schwab Foundation for Social Entrepreneurship. She's also an advisor to National Commission of Enterprises in the unorganized sector. She's also a commissioner in the World Health Organization's Commission on Social Determinants of Health, and a member of high-level expert group on universal health coverage set up by the Planning Commission of India. 2010, that group, of course, has wound up. She was a member of the National Advisory Council of the Prime Minister of India in 2010. Welcome, Mirai.
Thank you very much, Dr. Achal and Dr. Seshadri, for inviting me, and my apologies that I'm not there in person, because actually this month is the month of annual general meetings of solidarity organizations. So unfortunately, I have to be here. I hope you can see the screen. Can you see it?
Yes, Mirai.
Okay, good. So I'll go straight into the presentation then. Now we quickly change gears and transport you to the world of work of the informal economy, particularly informal women workers, like my Seva sister who is manufacturing inland salt, as you can see in the photograph. And I'm not sure whether many of you know the extent of the informal economy in countries like ours. It's almost everybody. ILO puts it at about 2 billion worldwide, or 61% of the global workforce. But in our country, as I said, it's almost everybody. Extremely economically active, particularly women, and contributing heavily, at least 50% to our economy. And yet, as you all would know, this is the poverty sector of our country. In fact, there is, as we have seen over the last 51 years of working at Seva, there is an overlap between poverty, informality, gender, and intersectionality. And of course, this links with the comments of the earlier presenter, Maiteryi, as well, that there's disproportionately large numbers of informal women workers who are from the poorest communities like Dalits, Adivasis in our country. And it is to remedy or to try and address some of these issues, the overlapping issues of poverty, injustice, and exploitation, which always go together, that our late founder, Ilaben Bhatt, began organizing workers, as I said, 5 decades ago. And it has been a slow and steady process of fits and starts. And today we are one of the largest organizations of informal workers in the world, but still a drop in the bucket for a huge country like ours at 25 lakhs. But what's interesting, I think, perhaps for this discussion is that one of the offshoots, if you will, of organizing women and uniting them across the country, across all faiths, ethnicities, religious groups, and castes, has been the creation of these small, medium, and some fairly large membership-based organizations. And I mentioned some of the forms there. And of course, they are inspired by Gandhian values. They're decentralized, they're local, they're close to where women live and work. And apart from, obviously, nonviolence and truth, Swaraj, Swadeshi, Sarvadharam, these are some of the guiding principles, which also have relevance, I think, to our discussion this morning. Very quickly, this is what the hardworking women of our country look like. The largest group are manual laborers and service providers. Women are the farmers of this country, as we know, the largest group, although titles of land and other assets are never in our names. So I'll just move on quickly. I think one of the things that we have seen right from day one, Ilaben was able to put her finger on the pulse, is that for the poor working women of our country, their central concern is work and livelihood. In fact, their entire lives are categorized by a quest for work and livelihood, some measure of work and income security so that they have better food security and social protection. This comes up all the time, even today. The other thing we've learned is that it's very hard for women to obtain livelihoods or some measure of livelihood security on their own. But when they come together in their own solidarity organizations, their membership-based organizations, then all kinds of exciting things happen, and they're able to jumpstart and catalyze livelihoods locally. It also gives them the strength, the collective strength and bargaining power to face injustices, both within the family, in their communities, because as we know, women in all castes and communities and classes are the most exploited and vulnerable, and also to confront exploitation by vested interests be it at the local level, be it, officials who they have to face, both within the home and outside, and of course, in the world of markets, where they never have a fair playing field. So I thought I would give you 4 quick examples. The first example, which was actually our first effort at a solidarity organization, was Seva Bank. Seva Bank is 50 years old this year. And remember, this was a time when women were called unbankable, when the microfinance movement, sort of invented by grassroots women, had not been discovered and lauded. And it was because women kept saying that they could not come out of poverty because they were bound hand and foot to money lenders or large merchants who charged them, 10% interest per day, keeping them in poverty, causing enormous stress and distress. And so a group of women got together. They pooled 10 rupees at the time, 4,000 women, 40,000 share capital, and they were soon on their way. Of course, it was a very bumpy road, and I can't go into the exciting story of Seva Bank, but from 40,000 share capital, today this bank, which is our first self-help and solidarity effort, is almost 600 crores. No grants, it's just the savings and hard work of, well, millions. The second example is from street vendors, and our street vendor campaign has been one of our signature campaigns. It took us 40 years to get the rights of street vendors to the Indian Parliament, and thankfully in January of 2014, street vending was finally recognized as a legitimate livelihood, and is protected now legally. But it took years of organizing and building solidarity and unity on the ground. And here's a really interesting case. These are informal workers who are not asking anything from the state. All they're asking is to be left alone. And yet they are kicked and harassed and beaten by the police and municipal authorities. Their goods are confiscated. One policeman was running a whole restaurant from the confiscated vegetables of our members. So this has been a major solidarity effort, bringing people together. Women said, if all the time our goods are confiscated, how are we going to feed our children? The stress levels, you can imagine what they were like. And this not only led to a national campaign, but it's an international campaign now for the rights of street vendors across all continents. The third example is the one that I've been most involved with, is that of service cooperatives. These are services which are very much needed by women, like childcare and healthcare. And we created a health cooperative of grassroots health workers and traditional midwives and dais. And we began with sort of our bodies ourselves, understanding how our bodies work. And many women said they had 6 children, but they had no idea about pregnancy and childbirth. And then one thing led to another. Then we started working on primary healthcare at a time when the government hardly was. And then we found that medicines was another major cause of keeping people in poverty. And so we started a chain of low-cost pharmacies, then an insurance cooperative, because women said they wouldn't go to hospitals because they didn't have the money to pay. They were indebted. So just to share that, these are some of the solidarity organizations. Yes, and finally, our latest sort of endeavor in Bihar is a farmer producer company, because in many districts in Bihar, as many of you would know, men migrate out to work, and it's women who are working on their land. And we help them get lower cost inputs like low cost seeds and certified seeds and so forth, and marketing, and then technical inputs and so on. So all of these efforts, what have they led us to? Well, for start, we think apart from the solidarity, it has been a deepening of democracy. We often say these are laboratories of democracy, because in these solidarity organizations like cooperatives, it's one woman, one vote. They are inclusive. They respect diversity because they're based on a common need. So it doesn't matter whether you're this or that community, but if you need childcare or if you need low-cost seeds, then you are welcome. So respect for diversity, and I'm going back to what Dr. Achal, Dr. Shekhar put up, the inclusivity, the respect for diversity, compassion, and acknowledgement of interdependence. So all of these things play out in these solidarity organizations, which someone I thought was interesting description, called them horizontal solidarity organizations, which of course they are. And another sort of quick point I wanted to make was even things like a daily prayer. In the Gandhian tradition, we start our day with a Sarva Dharam Pratna. And we feel that in good times and bad, this is really, particularly in a state that's prone to communal violence, this has held us in very good stead. On the inclusivity, just a quick word. When we start organizing, we proactively go to the Dalit bastis or the Adivasi bastis, because it's important to be inclusive from the beginning, not as an add-on later on. In fact, all of our community-based health workers are drawn from these very communities, disproportionately from the Dalit community. The other thing I wanted to mention, and I think is important, is the whole issue of social protection and services. One thing is creating livelihoods through solidarity organizations, but we can create social protection also through solidarity organizations. And I mentioned our health cooperative. I think the women who we work with put it very well. They say these are two sides of the same coin. You can't have livelihood, work security without social protection or social security. And this is essential for building resilience. And in our experience, at least the elements that I've put up on the slide are critical if women are to emerge out of poverty and if they are to be strengthened. I thought I'd mention a few things. Actually, in our primary healthcare, community-based health work, mental health is, like for everybody, unfortunately come relatively late. But fortunately, now we are working on this issue. And we have learned, like many of you, that it is an integrated approach, that livelihood is critical along with social protection and financial services, but also capacity building, including for mental health. And also that mental health at the grassroots, people see it as a whole. Those of us who are professionals, our minds get compartmentalized, but at the grassroots level, it is an integrated whole. So it is the primary healthcare approach, even integrating with occupational health, which along with mental health is a very neglected area, as if women aren't workers, they're just mothers. And we also feel that mental health at the workplace, I already mentioned in the market, the kind of harassment that street vendors face. Now, this is also a whole area that we are only now beginning to look into. I just wanted to mention that after the earthquake in 2001, what really struck us when we went into the devastated villages of Kutch and the other districts was that the first thing women said was, they didn't say, give me help, give me relief. They said, have you brought work? Because they understand that work and livelihood is a part of rebuilding, resilience, rehabilitation, and also, getting them out of the trauma of what they had witnessed and gone through. For us, partnerships with mental health professionals, because we are not mental health professionals, we are learning from you. We're learning from Sarthak and Sangat and other organizations who have a wealth of information and expertise in this sector. So we do need that technical support. Unfortunately, we have been reaching out and building these partnerships. And not with the organizations I mentioned, but one of the things that we find even with Gujarati language counselors in our state is that it's not simply the language, it's awareness of the reality. They're unfamiliar, as has been mentioned by a previous speaker. Many of them are urban middle class. They don't know the world of work of informal women workers. And they haven't been exposed to it, but that becomes then a barrier. One of the things that we have found, which is very effective, is training of local women leaders, who in Gujarati we call agevans, those who take sort of ageka action, on the front lines, if you will, but also put others before themselves. So these Agewans are trained to provide services at the doorsteps, as you can see in the slide, including door-to-door education, working with the primary health centers on NCDs, organizing camps, and so on. And most importantly, they are trusted. They understand the culture and context and provide locally relevant solutions. And the fact is that they don't just work on mental health. They have garnered this trust after years of work, helping women get their entitlements, helping them get access to government programs, etc. The support that we've been trying to offer is both online and offline. Of course, during COVID, online support was forthcoming from many people, but we want to continue that, including offline support. But what we find interestingly is that the Agewans have to be on the call. It's where the people who seek care, mental health care and counseling and whatever support, they're very keen that the Agewans are there with them, sort of like almost translating or interpreting between the professionals and between people. One of the things we've been struggling with is identifying the gaps and mapping the existing services and services that are available in a sensitive and culturally specific manner, not blaming the victim, not blaming the patient. And those, as we know, are not easy to come by. And finally, as others have also mentioned, the importance of education and awareness. I mean, people just don't understand mental health. They don't understand the connections with other aspects of health and so on. So there's a huge task waiting to be done. But we have faith that it's these simple women of our country who even during COVID showed they were second to none, and they were out there on the front lines, who will be able to take this, because as we know, we don't have enough mental health professionals to go to every village of this country. But they are willing to work, if only we give them a chance. Finally, I thought the COVID experience brought out some very interesting points. What we learned is when you have solidarity organizations, horizontal solidarity organizations, decentralized on the ground, like cooperatives, like women's self-help groups, then you can not only move quickly, but you can also, you're close to what people want, what are their needs, and you can reach them quickly as well. One of the things we were able to do was to pivot our handicraft cooperatives into making masks. Our health cooperative, which also produces Ayurvedic formulations, began to make sanitizers and soaps and so on. So actually, it wasn't like all the livelihoods came to a grinding halt. The second was that because these cooperative solidarity organizations had been working for years, they had built up their reserves. Over the years, very modest surplus profits, which then by law are put into reserve funds, development funds, and these could be used to provide cash transfers to their members, a lump sum, so that people could at least eat and buy medicines and so on. Also healthcare, apart from providing health kits, and then because we had this network on the ground, the health cooperative had been working a lot with the local public health authorities. We were quickly able to get people to where they needed to be as much as we could in those trying times. But also the whole issue of mental health came up, and we were able to link with mental health professionals because they also proactively sought us out. Childcare was another major issue. Men went back to work, but it was a long time, way beyond January 2022, when women could go back to work because they had to stay home to take care of the children. Schools were not open. Childcare centers were not open. Who's going to take care of the elderly and the sick? I mean, one thing that women repeatedly say to us, and one of our, again, campaigns is for universal childcare, is that we cannot work and earn if we have no system to take care of our young children. And plus, it gives us peace of mind. We can earn in peace knowing that they're well taken care of, they're fed, and they're learning something new. And finally, what we learned during COVID was how courageous the grassroots women of our country are. It strengthened their leadership. Many of them post-COVID were asked to stand for election in panchayats because they were there on the front lines. The male family members said, no, don't go. But they went. They went and they served. And finally, I thought on my last slide, some of the things that we've learned all these years at Seva on building resilience. And I think for us, there's no shortcut. The first and most critical building block is the act of uniting people in this mind-bogglingly diverse country of ours, uniting all castes, communities, ethnicities, linguistic groups, so that nobody feels left out, nobody feels left behind. And we've also learned that this serves as a critical sort of support group. In fact, once a WHO mental health director said, "Are you aware that your entire organization is a massive support group and a solidarity group and a major mental health intervention?" And we hadn't thought of it that way, I must say. And also leading to livelihoods and social protection. We find it's very hard for women, as I've stressed earlier, to either access services or livelihood without their own solidarity organization. I've already referred to the building of leadership of women, but also their knowledge and skills. And we are in the process now of training the next generation of Agivans. We are on to the fourth generation of Seva grassroots leaders. And it's a slow and steady process with ups and downs. But we think that they are critical in every way, not just for mental health or social determinants of mental health, but basically leading our country into a peaceful and democratic future. Yeah, I already mentioned two sides of the same coin, work and social security. One with the other doesn't really make sense. That's what we've learned from our sisters. I think another issue that comes up, which I've just skimmed over, is the issue of care and services, support services for women. The whole issue of peace of mind they keep bringing up. And now post-COVID, as you all know, the care economy and care issues has taken center stage and high time. And it's a welcome development. And it's from both sides. One is care as a livelihood opportunity. I know Dr. Achal keeps saying there's a crying need for people who can support people with mental health issues. So there's that aspect, but it's also the aspect of providing support services to women so they can join the workforce, they can earn, they can bring food into the home and other essentials. Financial services, I've already mentioned how this not only keeps women in poverty and their families in poverty, but is a major stressor. But the important point here is the package of financial services. Usually people think of just giving loans. That's only part of the story. As you can see from the slide, it's a question of financial literacy, pension, and importantly, insurance. Because women particularly, we still don't do health seeking because, who's going to pay? For the husband and the children, they'll go into debt, but not for themselves. I mean, it's improving, but that's still the case.
Mirai, we are running short of time.
Yeah,
we are out of time.
Last 2 points. Sorry about that. Yeah, so capacity building, and then importantly, voice and representation. This is very important. A place at the policy table, including in all discussions on mental health. So thank you very much.
Thank you, Mirai. I'm sorry I had to intervene. Important things, and Shekhar will summarize, and I'll just... The important things are scale is possible. If you have existing community-based organizations interpolating mental health into their work, scale is possible. Seva has demonstrated that, and mental health interventions lie much beyond room-based clinical interventions. Those are the two learnings for me from Mirai's. Shekhar will summarize for a minute, and
we're going to leave you with an image. We realize, friends, that social determinants of mental health would actually need to be the subject of an entire 3-day conference, or perhaps a 3-year course on mental health. And in 90 minutes to really look at the depth and the width of what we have attempted to present to you, starting with Mirai and the Seva program on the one hand, and what a mental health initiative such as Mariwala looks at various pockets of the country, particularly pockets where there are vulnerabilities that arise out of social determinants and clients to work within the resources in that community to actually build resilience, to look at particularly vulnerable populations and the context that they come from, and see where mental health needs to re-examine itself, to what Achal pointed out as some of the emerging, if I may use the word, threats or certainly challenges that things like artificial intelligence are likely to pose for us. This is the frame of reference that we wanted to present to you as a part of the culminating plenary of this conference. Achal is going to leave you with a couple of slides, and I realize that there are many of you who want to say and share things, but we will do so over the recess as we finish
Right.
this session.
So I'll leave the slides to be, this is it. We have to acknowledge an act. But the important thing is the conversations need to go on. As we've realized that we're living in different universes. Yesterday or day before yesterday, when we were talking about social determinants, we were talking about one way of doing it. Today, we are talking about yet another way of doing it, which is already there. The two worlds have to marry with each other, or at least have a relationship of some sort. Marrying is a difficult thing to say, but have a relationship, or tenuous relationship, or a discourse-based relationship. We can't continue to live in different isolated worlds. I, as a psychiatrist, don't go to psychiatry conferences. I thought Shekhar and I should come here and talk about this to try and bridge the two worlds. Thank you very much.
Thank you.
And
Thank
also, Shekhar and I might be coming up with a blog on the Samvad YouTube channel to talk more about the social determinants. Thank you.
Thank you, Maiteryi. Thank you, Priti. Thank you, Mirai. And thank you, friends, for your